Hi, everyone, and welcome to another Community Chats. My name is Sandra Arevalo, and I'm the Director of Community Health and Wellness at Montefiore Nyack Hospital. And today we're going to be talking about depression, but one depression in particular is smiling depression. I know it sounds kind of antagonist because if you're depressed, you're supposed to be sad, but then you're smiling. So we're going to learn more about smiling depression today with our guest speaker, one of our favorites. I'm saying our because it's not just me. Our guest speaker today is Aaron Selwyn, and he is actually from our pharmacy department at Montefiore Nyack. But I'm going to let him tell you all his degrees because I know that I'm always short on that. But the specialty for Aaron is pharmacology around depression and mental health and all these issues. And as a matter of fact, he works here in our mental health unit. And who would have thought, because I always thought that pharmacists were just in a pharmacy, they wouldn't be in the units, but he is different, obviously. So welcome, Aaron, and thank you for doing this. And you're a rock star. Let me just say that. You're a rock star.
Thank you, Sandra. Thank you for having me. Really happy to be here. So I will just briefly introduce myself and then we can get started. I'm Aaron. I work as a clinical pharmacy specialist at Nyack Hospital. I work predominantly on the behavioral health unit. My training is as a pharmacist, but I have a little bit of extra training in behavioral health related fields. So that includes disease states such as anxiety disorders, depressive disorders, mood disorders or bipolar disorder, schizophrenia, and substance use disorders. And so I work very closely with the physicians and psychiatrists on our unit, our social workers, our nursing staff, to help develop an evidence-based, safe, and effective medication regimen for patients while they're receiving inpatient psychiatric care. Along with that, I also run 3 medication groups a week, 2 groups on the behavioral health unit, where I answer questions about medications, how they work, side effects. But we also spend a lot of time doing psychoeducation, talking about different disease states, talking about different non-medication related approaches to dealing with stress, dealing with anxiety, coping skills, things like that. And I also do a group that's similar on our substance use unit. We have a detoxification program as well as a 28-day rehabilitation program for people who are using various substances in the community. So I'm happy to be here and to talk with you all today about depression. And as Sandra mentioned, we will have an emphasis on smiling depression, or another way to describe that is atypical depression. But before we get into the meat and potatoes of atypical depression, I thought we could spend a little bit of time going over major depression, and really atypical depression is not that different. It's just a presentation that is not as common. And as far as, how common does smiling depression occur? How prevalent is smiling depression? Researchers really haven't done a great job at really picking out the prevalence of atypical or smiling depression. But I thought if we had an understanding of what major depressive disorder is and what it looks like, that may help us get an overall better understanding of the illness and maybe how we can differentiate smiling depression or be aware of different presentations. So let's get into it.
And while you get to your slides, I just want to remind everybody this space is for you. And please ask questions, send us comments. If you have anything in particular that you want to learn about this topic, please write it down in the Q&A, in the chat. Somehow just communicate with us, and we will be happy to answer all those questions. So please take advantage of this time with us.
Yes, as Sandra said, please feel free to interrupt me as well. Okay, so let's just first begin talking about major depression or major depressive disorder. It's the fourth most disabling disease worldwide, according to the World Health Organization. So, if someone is in the thralls of depression, it can be incredibly debilitating. People lose productivity, they lose their ability to earn money, to take care of not only themselves, but to take care of other people. So if they have responsibilities to children or maybe taking care of elderly adults, these responsibilities are often not kept up with due to the severity of depressive symptoms. So it occurs about 7 to 12% of the population in the United States. And recently, one thing I think that's important to comment on is during the beginning phases of the COVID-19 pandemic, we saw a really strong uptake in the incidence of people reporting depressive symptoms as well as suicidal ideation. And that I think it's pretty easy to understand that, but people were very isolated. Their routines were thrown off. They weren't able to do the things that they normally did to take care of themselves. Um, in terms of people that are receiving treatment for just overall medical care, about over 10% of these folks will have, or maybe at one point have met criteria for major depression. And this next point is really important. So about 75 to 85% of people will have recurrence. So one of the questions I get all the time when I'm working with people who have depression or they're in our hospital for depressive symptoms and we begin treatment, whether that's with a medication or a non-medication treatment like psychotherapy, they ask me, how long do I have to take this medication for? And that's a big question, and it's sometimes not as a straightforward of an answer as people would like. But I generally say let's stick with this treatment, especially if it's working, for 6 months to a year, and then reevaluate. But what we're finding is if people who have more recurrent episodes, or if they get better from their depression and then the depression returns, the more episodes that someone has of depression in their lifetime, the more likely they are to have another episode. So if someone has been living their life and not having any problems and then had one episode of depression that was treated and resolved, I may say treatment for depression is not indefinite, but if someone has had multiple episodes of depression, maybe even a suicide attempt, I would encourage them to continue with their, whether it's an antidepressant or some type of psychosocial treatment, because the odds of symptoms occurring are pretty high.
Ah,
And, oh, yes, go ahead.
there are some people that are scared to take medications for depression because they say it's addictive.
Sure, sure. I get that concern, really on a daily basis. And so, and as we get through these slides here, we'll talk a little bit about the antidepressant medications, but generally our standard class of antidepressant medications, so I think of our SSRIs, our selective serotonin reuptake inhibitors, there's various other classes of medicines also, but these medicines are not really addictive. However, the body can become dependent on them, and addiction and dependence are different. Addiction to me is more of a behavioral component where someone is actively seeking a substance or a type of activity, or but physiological dependence is when the body just gets used to having a medication in the system, and then if it's withdrawn rapidly, then they may experience a mild withdrawal symptom. But antidepressants, people do not crave to take an antidepressant, but if there ever is a plan to discontinue treatment, I would say to decrease the medication gradually. But These medicines are very safe. A lot of these medicines can even be taken in pregnancy or in children or in older adults. And we're always monitoring the individual to see if they have any intolerances. There is a black box warning with antidepressants up until the age of 24 for increased risk of suicidal thinking. Now, this again, does not happen in everyone, but we've found that younger people tend to be more prone to developing adverse effects in terms of suicidal thinking with antidepressants. But we have to weigh the risks and benefits in all patients. Is the risk of this medication greater than the risk of untreated depression or anxiety? And generally, I'll answer that question to say that the risk of the medication is not greater than untreated mental health issues. So that is really how I would answer that question. I hope that was helpful. Um, Anything else, or shall I keep going?
Yeah, go ahead. Keep going.
Okay, I'll keep going. So, um, people also with depression, sometimes there are different or people with different medical issues may be more prone to developing depression. There are also different classes of medications that can cause or mimic depressive symptoms. So before we as clinicians jump to a depression diagnosis, we want to make sure that there's nothing else that could potentially be causing the symptoms such as depressed mood or sadness. So we do as thorough as an evaluation as we can. But we do know that people who have major depression have a higher risk of suicide, certainly, of heart or respiratory disease, have a greater risk of accidents and stroke. And so by treating depression, we can hopefully lower these risks, but untreated depression puts people at a greater risk of really a variety of things going wrong. Now, how common is depression and when does it most commonly occur? So, in most folks, the onset is in the late 20s. There certainly are individuals that experience depression earlier on in life, in adolescence or late teenager years, but the onset's most common in late 20s. You can think of that time as when maybe an individual is expected to leave the nest, so to speak, and to go out on their own and try to create a career, try to create a life for themselves. And sometimes that's when people are faced with disappointment, challenges, things don't go the way that they planned. And also there's a biological component to when depression develops as well. So all of these things in mind, most commonly onset in the late 20s. Females, the incidence of depression in males and females seems to be about the same until puberty takes place. Once puberty hits in females, it seems that the lifetime risk of depression goes slightly up in greater risk for females. But there's another thing to think about, and it especially hits on our main topic of smiling depression, is men may not be as forthcoming about symptoms of depression. They may try to shrug it off and just try to produce a tough exterior when inside they're not really doing as well as they'd like to be. That being said, peak onset of depression for males seems to be later in life after the age of 55. This is maybe around the time of you could think of like a midlife crisis or where people are starting to question their achievements and starting to question their purpose as they get a little bit older. However, the incidence is slightly lower in older persons than the general population. And one thing that is also interesting to think about is in older people who do develop depression, if we treat them with antidepressant medications, the antidepressant medications seem to have a very protective effect in our older depressed patients. How do we diagnose and classify a major depressive disorder? So the DSM-5, the Diagnostic Manual for Psychiatric Disorders, classifies depression as a mood disorder, and it can be a single episode or recurrent. And there are various other specifiers here, so dysthymic disorder or depressive disorder not otherwise specified. And there are general criteria that clinicians will assess for to see if people meet A, B, C, D, etc. of the diagnostic criteria of major depressive disorder. Now, we tend to take these with we use the criteria, but we're not, if someone reports to you that they are feeling depressed and they may not meet the entire criteria, if their mood symptoms are debilitating and affect their ability to do the things that they want to, then to me, that's depression and it requires treatment. Um, the incidence of a single episode occurring is almost 50% of individuals. So it's normal for people to experience sadness, to experience grief. I think all of us at one point in our lives have experienced that. But if the worry and the dread and the depressed mood persist for longer than 2 weeks and are significantly impacting your ability to do the things you want to do, then that may classify as a depressive disorder. Um, and the average number of episodes in a lifetime is 6. So like I said, generally, the more episodes an individual has, the more likely I would encourage them to stick with treatment. But as we know, this is a recurrent illness. So the more that an individual sticks with treatment, the more or the less likely they are to have a return of symptoms.
So, Ari,
Yeah,
just
go ahead.
to
Sure.
make this clear,
Mhm.
what do these episodes look like? It sounds to me like you might have chronic depression, right? So you are diagnosed with depression, you will have depression forever, let's say,
Mhm.
but it acts up once in a while, up to 6 times. But
Mhm.
what do those episodes look like?
Sure. Great question. So I'm going to jump one slide ahead here. So these are our target symptoms in depression. And so when I work with learners, and this is what I learned in school, is the mnemonic SIGI caps, but we can add a D in there for depressed mood. So these are like the main symptoms that will make up a depressive episode. And every individual will experience depression differently. So again, this kind of casts a wide net as to what clinicians are looking for when someone comes to them uh, saying that they might be depressed. So depressed mood is just as it sounds, feeling down, feeling sad. Some people experience a depressed mood through becoming tearful at events that, someone who is not feeling depressed would not shed a tear at. Sleep. So sleep can go one way or the other. People, and a more common sign in atypical depression is hypersomnia. So people sleeping much more than usual. Most commonly in major depression that is not atypical, people tend to have insomnia or have difficulty falling asleep or staying asleep. They may toss and turn. They may feel that their mind is racing as they're thinking about all the things that they could possibly or that could possibly go wrong in their life. But either way, sleep is impacted one way or another. And that's kind of one of our probably the most important question in psychiatry is how have you been sleeping? And depending on how the person answers that, that can give the clinician a lot of information. Next, in the I in SIGI caps is interest. So loss of interest in things that you've previously enjoyed. So activities, maybe walking or exercising or playing tennis or pickleball. Also including loss of interest in sex, or the sex drive is much less than usual. Guilt, feeling guilty about something that the individual may have absolutely zero control over something bad that happened, but they may take the majority of the blame upon themselves. energy loss. So imagine, this goes into hand in hand with sleep, but people who have depression and specifically atypical depression tend to feel this chronic fatigue. They may go for a medical workup to see if there's something wrong with them physically, and the results oftentimes will be negative, but their depression and their low mood is what drives their lack of energy. And along with that, difficulty concentrating. So imagine someone who is a high performer at work. Then all of a sudden they're in the depths of a depressive episode. Their productivity may go down significantly. They have a hard time concentrating. They may make more mistakes. They may miss small details that they usually catch. Or it could be something not work related. They just may not be able to read a book or to watch TV or to read a magazine or newspaper as they normally would because they just cannot seem to focus on the subject. Appetite, change in appetite. So in depression, we see most commonly a loss of appetite. So people are just lose interest in eating. So that may be accompanied by weight loss. On the other hand, it can happen where people tend to eat more than usual. They tend to quote unquote eat their feelings, or they go for foods that tend to be more comforting, more maybe carb heavy foods or foods that they would only eat on special occasions. They may gravitate towards those more because they are the only things that are bringing them some joy in their life. Then next is psychomotor. So that has to do with movement or speed of speaking, speed of completing tasks, and it tends to be much slower. An atypical presentation of this may be agitation or irritability. Younger people, especially kids or adolescents, may present with more irritability, and that may be a sign that they're feeling down or depressed versus older adults who may move much slower. This is something that we call paucity of speech. You may ask them a question and they may answer, but they may speak very slowly, and you may have to spend a lot of time with them to really get an idea of what's going on. You can almost think of like how a sloth moves. They move very, very slowly, and that has to do with their depression kind of weighing them down. And then lastly, suicide. So that is not always a suicide attempt, but it could be suicidal ideation. And that's just thoughts of death or thoughts that I'd be better off not here. And we take these thoughts very seriously. Our clinicians are required to ask every patient that we see about their suicidal or suicidal thoughts or ideation. Do you have a do you have thoughts of wanting to hurt yourself or others? And if the answer is yes, we take it one step further and ask if they have any plans or idea as to how they would do that. So these types of symptoms are really what we're looking for when we say, or when someone comes to us with concerns of depression. I hope that kind of paints the picture of what depression looks like, Sandra.
Yes, definitely does. Now, one question about suicidal ideation.
Mhm.
That every type or form of depression comes with suicidal ideation, or can you be depressed without thinking about committing suicide?
Sure, that's a great question. You certainly can be depressed and not have suicidal ideation. It's definitely not a requirement. We tend to think that suicidal ideation will develop when people have really hit the severe depression mark. So people can be frustrated with how they're feeling, but can still certainly have a vigor to get out of it and live. So it's definitely not a requirement, but if suicidal ideation is present, to us, that indicates that there's more of a severe depression going on. Yeah, good question. Okay. Anything else, or my next slide is
Go
moving on.
ahead.
Okay. My next slide here is on treatment options. So these are more typical treatment options in terms of medication when it comes to treating depressive symptoms. So we have our older first generation antidepressants, which we really don't see that often anymore. We're mainly focusing our pharmacotherapy on these second generation antidepressants. So that's our SSRIs, SNRIs, drugs like mirtazapine or Remron and bupropion or Wellbutrin. But our SSRIs, for example, are drugs like Zoloft, Lexapro, Prozac, Paxil, things of that nature. And SNRIs are drugs like venlafaxine or Effexor or duloxetine or Cymbalta. Now, these medications work to increase the availability of serotonin. In the SNRIs, that N stands for norepinephrine. So norepinephrine is kind of your get up and go excitatory neurotransmitter. So it's thought that if we boost the availability of norepinephrine, it may perk people up and give them a little bit more energy. Now, it's certainly, you may have heard as depression being described as a chemical imbalance. This is kind of a simplistic, old school thought about why does depression occur. Odds are it's a lot more complicated than that. But in terms of explaining how these drugs work, these drugs will increase the availability of neurotransmitters serotonin, norepinephrine, and drugs like bupropion increase the availability of dopamine, which is our feel-good neurotransmitter. And it's thought that by increasing the availability of those neurotransmitters, letting them kind of become more available in our brain, then we are able to see an improvement in depressive symptoms, a reduction in anxiety, and a return to usual functioning. So the mechanism of these drugs and the way I've described them is certainly oversimplified, but it helps to just seemingly tone down the intensity of the worry and the concern and to help people to manage stress and deal with the uncertainties of life better. Now, our non-pharmacologic therapies are probably going to come into play before we even talk about medication. And these are things like psychotherapy, so working with a counselor, a therapist, a chaplain, even having discussions with family members of friends could be considered as a non-pharmacological approach. And in the different types of therapies, there are various strategies out there. There's cognitive behavioral therapy. That's probably one of the more popular ones in our society. There's mindfulness-based therapy. There's transference-based therapy. There's all different types of techniques to provide therapy. But what seems to be the core reason why people improve is not the modality, but the relationship with the person who's providing therapy. So whatever type of modality someone is practicing, as long as you're able to have a connection with them, whether that's in person or virtually now, that's what's really going to be driving the benefits of therapy. And a lot of times patients will do best if they combined these non-pharmacological approaches with medication. When someone is in a severe episode of depression, they're not really feeling like engaging in therapy, or they don't really have the ability to put their best foot forward in these non-pharmacological practices. So when I'm talking about medication with people who are feeling anxious or depressed, I will talk about antidepressant medications as tools. These are things that you can have in your tool belt, in your fanny pack to help you engage in therapy. And you may get to a point where after the medicine is kicked in, and mind you, sometimes these medicines can take up to 6 weeks to see a benefit. After the medicine has started to kick in and people are more able to engage in therapy, then the need for medication may fall off. Another non-pharmacologic approach to depression and anxiety is exercise. Exercise is probably the best thing that someone can do to help get them out of a depressive episode or funk. However, when someone is feeling overwhelmingly depressed, the motivation to go to the gym or to go for a walk or to do some push-ups is often not there. So a medication can help ignite the process. And then once people start adopting these more healthy behaviors, then the need for medication may go down. Any questions about any of that, Sandra, or anyone?
Not so far. I think we're good.
Okay, great. So these again are our hallmark treatments for depression. Augmentation strategies. So we have some of our newer medications that we can use in combination with these antidepressant drugs that were formerly really referred to as antipsychotics. I like to call them serotonin and dopamine antagonists because these antipsychotics are doing a lot more than treating patients with thought disorders or helping resolve symptoms such as seeing or hearing things that aren't there. So sometimes a booster serotonin and dopamine antagonist may be a drug like Abilify added to one of these antidepressant agents can make the world of a difference. Talking a little bit more specific into atypical depression symptoms, as I mentioned, atypical depression or smiling depression is really not going to be that different than just a major depressive episode, but certain individual symptoms may present slightly different. So people may have more of a persistent feeling of sadness or hopelessness, and they may reference this in conversation very subtly. So if you suspect that someone who is maybe a pretty high functioning person may be experiencing smiling depression, pay really close attention to the words they use to describe themselves. They may have persistent anxiety or irritability. People who have anxiety accompanying depression tend to have a more severe case or a more treatment-resistant case of depression if anxiety is also there and also bothering the individual. We mentioned sleep as something that is really an indicator of overall functioning. A good night's sleep can make the world of a difference. And one psychiatrist I practice with says that sleep is the best mood stabilizer. So if sleep is impaired, of course, an individual is more vulnerable to anxiety and depressive symptoms. But generally, in atypical depression, sleep is more prolific, whereas in major depressive disorder that is not atypical, it's more likely that an individual will have insomnia. Loss of interest in activities that were once enjoyable, difficulty concentrating, making decisions, and remembering things. So this is we can think of as like executive functioning. So people who are depressed, they feel cloudy a lot of the time. They may question their own decision making, and thus that causes them to waver back and forth when making decisions. Low energy or fatigue, and of course, talking about suicide. We couldn't have a talk about smiling depression without a quote from Robin Williams. And so he says, all it takes is a beautiful fake smile to hide an injured soul, and they will never notice how broken you really are. I think this is a pretty powerful quote. As you know, Robin Williams suffered from pretty significant period of depression at some point, and most points throughout his life, but you would never know it. He always had the smile on his face and he made other people laugh. So I think this Robin Williams is just one example of course, many people who have had this experience, but always checking in with people, checking in with friends and family. If you haven't heard from someone in a while, send them a message, give them a phone call, see how they're doing. Because even though it seems like a small act, it may make a huge difference in that individual's life. So what are some warning signs that we could look for in people? Well, notice inconsistencies. Is maybe the quality of work or the quality of conversation drastically different from one week to the next? Or is there something about them that just does not seem right? Is there a change in behavior? So we talked a lot about people just not engaging in things that they normally do, but are they now engaging in behaviors that could be potentially harmful? Have they picked up smoking? Have they increased their alcohol or cannabis use? Are they engaging in more risky type behavior? Or the opposite, are they just staying to themselves and isolating when generally you know them as being a more social person? Do they openly express feeling hopeless or empty? Maybe even as a way to be funny or to make a joke, maybe even a sarcastic statement. But are they saying these phrases that maybe have a little bit of alarm to them or to you, but to them they play it off as just being silly or a joke? Physical symptoms, this is a huge one. So a lot of times people with anxiety or depression will complain of headaches or stomach aches or just pain in general. And so they may not be able to really pinpoint what's causing them to feel physically unwell. Difficulty expressing emotions. So they may struggle with really trying to share their thoughts about how they're feeling. They may avoid that topic in general. If someone asks, they may kind of put up their defense mechanisms and really deflect questions to avoid answering them truthfully. And that goes with number 6 in avoidance of discussing emotions. Changes in social behavior. So that is maybe different than changes in behavior in a sense that the way that they are around other people have changed. Maybe you normally see someone as being the life of the party, and now they are more quiet or sullen, and they don't provide their usual spark that you're used to in conversation. Perfectionism. So people who are experiencing depression may be hypercritical of themselves. If something doesn't turn out exactly as planned, they may take that grief and disappointment on themselves in an exponential manner than what truly is the concern. Or they may spend excessive amounts of time trying to make something as perfect as possible when it's not necessary. I mentioned increased substance use, so that whether that be alcohol, which is a depressant, so people oftentimes will try to self-medicate their feelings of sadness with alcohol to maybe numb their feelings, but we know alcohol as a depressant is really just fueling their depression and making things much worse. But same could be said of cannabis or really any other drug. And then lastly, just trust your gut. If you've known someone or have concern and they are presenting in a way or behaving in a way that you feel is not their usual self, ask them, how are you doing? Is there anything that I can help you with? And they may not be open or upfront initially, but just being there with them and showing that, hey, whatever's going on, I'm here to walk with you as you go through this journey here. That can make the world of a difference. And lastly, I'd just like to leave this message here. This is the new and improved suicide hotline or suicide and crisis lifeline 988. People can call, text, and talk with an individual 24/7 if they're in crisis. Generally, depending on the severity of the crisis, an individual from this hotline may reach out and contact more or authorities to perform a wellness check or just ensure that the individual is safe. But this type of resource has saved a lot of people and can keep people from having to experience maybe a suicide attempt, an overdose, or a hospitalization. So it's nice to know what resources are available in the community. So, Sandra, that's really all I've put together here, but I'm happy to answer any more questions to the best that I can.
I like how humbly you say, that's all. That was a lot. So thank you, Aaron.
Sure.
Um, Here is a follow-up question. What would you say is the difference between regular depression and this atypical or smiling depression?
Yeah, I mean, I think the biggest difference is how debilitating it may be to an individual's job performance. Um, Atypical depression, people may be able to power through, or the smiling depression, people may be able to put themselves together, paint a pretty picture when they're around others, but then when they are alone or are with are the expectations of them are no longer there, that's when the symptoms tend to come out full force. But truly, it can be very difficult to tell the differences, so much so that researchers really haven't been able to pinpoint how common smiling depression really is. But I think an individual who is really high functioning, whether that's in a career or academically or also socially, people with smiling depression may just be able to connect with individuals very easily. They may come off as a very social or fun person, and thus people may not suspect that they truly have their own difficulties that they're dealing with. A lot of times too, depressive symptoms will develop after a trauma or a serious loss or event. So maybe if people are unaware that someone has experienced something that has been so traumatic to them, and it could be of no one's fault. Sometimes, or a lot of times, people who have had traumatic experiences are not open to really talking about them, especially with people that they're interacting with in a workplace environment or even socially. So it just may be really difficult for people to gauge what someone has gone through. So I think I tend to take the approach just smile at everyone,
Mm.
because I don't really know what people are going through. That I think that tends to, you know, a smile at someone towards someone who is not suffering depression doesn't really seem that significant. But for someone who is really going through it, holding the door and saying good morning could make all the difference for someone.
Mhm. So uh, would it be correct to say, because this is what I'm hearing from our talk, like regular depression, the person will show symptoms everywhere, but the atypical or smiling depression is like you are okay in public, but you're
Mhm.
not okay by yourself.
Possibly. I'm certain there are many people who have this regular depression that have a similar presentation. I think there's a lot of overlap. I really do. I think the biggest difference may be related to sleep habits. I think people who have this atypical depression tend to be more hypersomnolent. They tend to sleep a lot more. That also, one thing we haven't really gotten into is bipolar depression. But people who have bipolar depression tend to also show some signs of this atypical depression. And so, if someone, especially if they've received many treatments with antidepressants and they haven't responded as well as someone as you would like them to, that may be a sign that maybe there's more to this depression than what we're seeing. And so, reevaluating for bipolar disorder, which we use different treatments. We use mood stabilizing medications with antidepressant effects, not our standard SSRIs or SNRIs, but it may cause us to rethink our diagnosis and to use different types of treatment.
Mhm. Yeah, it's interesting because what got my attention when I started reading about smiling depression was how we can have people around us that is really suffering and we are not even aware, right? And they're not seeking help because they might not even be aware themselves.
Right,
So,
right.
mhm,
That's a really good point. I mean, sometimes just recognizing that what you're feeling is depression. Not a lot of people may know that. I think there's a similar issue when we talk about postpartum depression. A lot of times, if in the postpartum period after a child is born, a woman may feel or may experience some intrusive thoughts or feelings of sadness, but they may not be able to link it to postpartum depression. So I think by just talking about it, trying to educate the community and the public about what depression looks like, I think that makes a huge difference. Obviously, in mental health, there is a huge stigma towards mental health conditions. So using your words carefully, um, person first language. So this is a person with depression, you know, trying to not put down people who are suffering or people who may be less fortunate than others. So I think trying to just be very mindful of the way that you speak to someone who may or may not be experiencing a mental health crisis or even having mental health symptoms. It's very easy to, or it's very common for um, jokes to be made or people to make statements that may be hurtful, and even if they don't realize it. So just being aware that not everyone is as fortunate to not be feeling down or depressed. So word choice and how you speak to people and also how you speak about mental health conditions, I think is very important.
Yeah. And Adam, there is a question that I've had for a very long time. I'm going to take advantage now that we have you here.
Okay.
What would be the difference between sadness and depression?
Sure. That's a good question. And I think it's probably one that's a little bit difficult to
It's like
answer.
the egg and the chicken, right?
Yeah, certainly a gray area. So sadness is a normal human emotion. And we don't want to shy away from feeling sad if there is a reason to be sad. That is how humans kind of
It's a
grieve.
coping
Yeah,
mechanism.
it's appropriate, exactly. So the difference I would say is if that sadness is prolonged, so maybe there's a reason for sadness, but we expect that to improve within a few weeks or a few months, but every individual will grieve differently. So if I grieve or I feel sadness for 1 month, it may be completely normal for another person to feel sadness for a year or so. But really, to me, what makes the jump between sadness and depression is impairment and overall functioning. So are you no longer able to take care of the things that you need to in your life? And you've become overwhelmed and overrun by this feeling where that's the only thing that is driving your existence. If you um if you are feeling sad, but you're still able to perform at work, to take care of your family, to do the things that you enjoy doing, then that to me is not depression.
Yeah.
But if your sadness turns into this overwhelming feeling where you can't leave your room, you're not eating, you're not taking care of yourself, then we've shifted into more of a major depressive episode.
And talking about the same, um, okay, you might have a reason to be sad, right?
Mhm. Mhm.
And then that same reason could convert into depression. Like, okay.
Sure, yeah, it certainly can. I mean, and I think that is probably one of the big reasons why people will develop suicidal thoughts or will develop depression is they've experienced something terrible, but their body is then not able to recover from that, and they kind of get stuck in that low
Mhm.
feeling. Certainly, people can develop depression without having experienced a trauma or having experienced anything, terrible. But generally, there's a major life event, a major stressor that at least provoked these feelings. And we see that a lot in our patient population. Something happens, whether it's losing a job, losing a relative, even losing a pet, can be enough to kind of begin the cycle of depression. And generally, if it's a loss, the grieving process takes its course and they return to their usual self. But in a handful of people, that doesn't happen and requires further intervention.
And Aaron, I think, but you're the specialist, so please correct me if I'm wrong. I think that a lot of people think of suicidal ideations like I'm gonna kill myself somewhere somehow. But
Mhm,
there is also a very tight relationship between chronic disease like diabetes, hypertension, heart disease, right? And
mhm,
depression
mhm.
and also suicidal ideations, because could we say that if the person is not taking their medications, is not going to a doctor's visits, and is not taking good care of themselves,
Mhm.
that could be a sign of depression and maybe even a suicidal
Sure.
idea?
Absolutely, absolutely. And a lot of times, especially the more complicated a medical comorbidity gets, it's very
Mhm.
people can become overwhelmed with all that they have to do to take care of themselves. And instead of using their resources to stay on top of that, they feel so defeated that they just stop. And so if that happens, then their depression runs haywire, their medical comorbidities run haywire, and the individual is at a very high risk of something, bad happening. So that's when we're educating people about their disease states, we want to assess how comfortable people are in performing the tasks that they need to in order to care for themselves. And if they don't understand, then is there some way that we can provide them support that they don't have to do this by themselves?
Mhm.
Um, Especially for diabetes, or even rating scales that clinicians can deliver to assess for how overwhelmed are you by all of this, and because there's certainly a link between that feeling and depressive symptoms, and then overall outcomes in managing the medical disease state.
Yeah. Well, this has certainly been very enlightening. So thank you so much. And for that question that we have there, yes, we're going to be sending the recording to all of you. And we have a new feature. Actually, Aaron, you'll be the first to know. We have a new feature in community chats. Now you can actually use the closed captioning, and you can see the same recording and read it in Spanish if you want, or any other language. So that's really great, because we can't be bilingual all the time in these recordings, but you can listen to it or read it in your favorite language. So please go ahead with that, and I will be sending the recording to all of you. Aaron, it's been great. Thank you so much. You know
Of
that I
course.
really mean it.
Thank you for
Uh,
having me.
and thank you for all of our attendees for being here. I hope that you like the topic and that this is useful. And I will see you next week.
Okay, thank
Thanks
you.
a lot, everyone.
Bye bye.
Bye.